Good afternoon, everyone, and welcome to this mentoring session this afternoon. We will be talking about postpartum depression, so close yet so far with Dr. Tennisha Edwards. My name is Nicole Fernandez, and I'm the Maternal Infant Health Series Project Manager at Wayside Recovery Center in Minnesota. We are a recovery center for women. We were one of the first recovery centers in the country that allowed women to bring their children to treatment. We have worked very hard for almost 65 years delivering gender-specific care, trauma-informed substance use treatment, mental health services for women and families, as well as we provide an array of holistic care, including outpatient residential substance use disorder treatment and recovery services. We also provide long-term supportive housing and family supportive services, which can include sometimes their alumni groups, and or parenting groups, and a number of other resources that we provide members in the community. This is our mentoring session where we have additional time with our speaker and presenter to talk, to problem solve at the end of the presentation, and hopefully to put some of these clinical considerations into practice. I also want to just share Wayside in this work that we've been doing over the last 2.5 years, we count it as a benefit and a really great opportunity for our organization to lead this work. We're able to lead this work by sponsors, which is Minnesota Department of Human Services and SAMHSA provide us with the State Opioid Response 2 grant, which provides this funding for us. Excuse me. And we try to make it culturally responsive and culturally sensitive, using asset-based language in the work that we're doing. And we really rely on attendees such as yourself to share wisdom, as well as share resources and great programming that might be happening around the country that you could share with us. We definitely are focusing locally with presenters and other partners who present the Project Echo series, but we also are not afraid of reaching across the state lines and around our nation to learn from one another. And so today our speaker is Dr. Tennisha Edwards, and I'd like to just read a little bit about her and share a little bit about her work. She is coming to us by way of Atlanta, and hopefully maybe when we've had an opportunity, I've had to ask about, upcoming conferences for next year. And so we are looking definitely to continue to network with community partners locally and nationally to support some upcoming conferences that will be here in Minnesota. And so without further ado, I'd like to just read a little bit about Dr. Edwards. Dr. Edwards is a Rochester, New York native, and she is a founder of an Atlanta-based Transformations Pediatric Health and Wellness, LLC. Dr. Edwards launched TPHW, citing the necessity of a reputable private practice expanding equitable access to preventative medical health care services among the underserved pediatric community. Also, as a board-certified pediatric nurse practitioner, she began her nursing career as a staff lead in the pediatric intensive care unit at the University of Rochester Medical Center in Rochester, New York. Currently, Dr. Edwards practices as a primary care provider and child advocate, working to ensure quality, culturally relevant, equitable care for the inner city pediatric population. Dr. Edwards earned her Master's of Science in Nursing from the University of Rochester and her Doctor of Nursing practice degree from Emory University with an induction into Emory Sigma Theta Tau National Honor Society chapter. She is a member of the National Association of Pediatric Nurse Practitioners and is a preceptor for South University, Georgia State University, Chamberlain University, Clayton State University, and the University of South Alabama, as well as Walden University. Dr. Tennisha is a staunch proponent of the core values of leadership, scholarship, and social responsibility in her community. Dr. Tennisha Edwards has a special interest in faith, church going, reading, traveling, singing, and spending time with her husband and sons. Without further ado, I would like to welcome Dr. Tennisha Edwards.
Good afternoon, everyone, and thank you, Ms. Fernandez, for such a lovely introduction. I'm very appreciative of this opportunity and the gracious invitation that you've extended to me, and I'm also grateful for the incredible work that you're doing there in Minnesota. It's very far-reaching, as I here in Atlanta, Georgia, am a beneficiary of all of the positive effects and hard work that you are doing there. So it's truly a testament to who you are. And I'm sure there are countless others who, as I do, truly consider you to be such a blessing. And I am grateful for all of you for joining me today. You didn't have to spend your afternoon with me for the next 2 hours as we talk about postpartum depression. And although there is great awareness on this topic, there's still so much more work that needs to be done. So before we actually get into it, let's look at the objectives. By the end of the session today, it is my hope to raise awareness about postpartum depression as well as the existing gaps and challenges while highlighting the importance of culturally sensitive and equitable care for women of color, to provide practical strategies and resources for peri and postnatal healthcare providers and families and their social support systems for the pregnant and postpartum mothers, and then also to promote dialogue between healthcare providers, researchers, and community organizations on the need for policy changes and systemic awareness and improvements so that we can address inadequate attention and thus care to diagnosed, the undiagnosed, and the untreated mothers and families affected by postpartum depression. And here is just a quick 3-minute video that I wanted to share with you that really is a testament to where we're at with this.
I've been looking for a product like this my whole life. We were all putting it on, looking in the mirror, and we're like, oh my God, this is a friggin'.
This mother has been charged with strangling her 3 young children. Her lawyers blame postpartum depression, and her husband is standing by her. But prosecutors say she knew exactly what she was doing. Amber Cagliano with the story that we should warn you has details that may be upsetting for some viewers.
How could this happen? A mom accused of strangling her 3 kids.
And you hear me?
Yes, Your 32-year-old Lindsay Clancy spoke from her hospital bed at her bail hearing. Police say she tried to jump out a second-floor window after strangling her children in the basement of her home. She is now paralyzed from the waist down. Clancy was a labor and delivery nurse. She even made videos for newborn mothers.
So there are a lot of benefits for both mother and baby.
Her lawyers say she was suffering from postpartum depression and postpartum psychosis. But prosecutors say she was clear thinking and planned the murders.
She used Apple Maps to make sure she would have enough time to strangle each child before her husband returned from where she had sent him. The defendant did not take advantage of the situation when her husband left the home that night. She created the situation.
The prosecutor said Clancy used an exercise band to strangle 5-year-old Cora, 3-year-old Dawson, and 8-month-old Callan.
She had to strangle each of them to unconsciousness and then make sure the bands were squeezing their little necks for several minutes.
Clancy's defense attorney says she was seeking help that did not come in time.
She was having bad thoughts. She was having worsening depression. This is clearly a tragedy.
Clancy's husband, Patrick, says he forgives his wife. And so does this man. You might recall Russell Yates. He's the husband of the notorious Andrea Yates, who drowned their 5 children in a bathtub 22 years ago.
The next step of forgiveness, I'd say, is understanding it's a sickness. Like in this case, you can do all you can at home, but you really can't protect yourself from a psychotic person at home. I mean, they get up in the middle of the night, light the house on fire.
George Parnham was Andrea Yates' attorney.
To come to a realization that you took the lives of the people that you gave life to, they have to live with this for the rest of their lives.
Dr. Catherine Berndorf treats women with postpartum depression.
She was not in her, quote, right mind when she made those decisions. She believed that by killing her kids, by killing herself, that she was probably helping them. She was not in a sane state of mind.
Dr. Berndorf says some patients will need to be medicated.
For postpartum psychosis, we often use at minimum 2 medications, a mood stabilizer and an antipsychotic. Those are 2.
So this was
Yes, I was
definitely,
able to
oops,
this face. In Primepro,
this was definitely an unfortunate event that took place just this year. So it's something that is ongoing. And I'd like to also jump into this first case study. I apologize. Is the top of my screen showing up for you? I just don't want it
Yeah,
to.
we can see everything fine.
Okay.
So, yeah, so when you click, go ahead and click and let's see if the other information show. There you go. Yeah. So they're arriving one at a time as a bullet.
Are you able to see the headings?
Yes.
Okay, I apologize. All right, so the first case study, we have a 21-year-old African-American female. She is pregnant with her first child. The pregnancy is going on unremarkably. Now the baby is full term at 40+ weeks gestation. It's a infant boy. She delivered him via spontaneous vaginal delivery without any complications whatsoever. And he was admitted to the regular newborn nursery. This means basically that there were no complications with him. He was healthy, and the both of them were discharged home in good condition. And so she is a stay-at-home mother by choice. There's no history of depression or any other mental illnesses. She's not on any kind of medication. Baby is getting along fine. Temperament is that of an expected newborn baby, and no colic. And the 2 of them seems to be bonding well, and there are no known stressors. So around 2 months of age, she starts having thoughts of killing her son. There's no clear-cut plan at this point, but then around 3 months, she starts keeping knives under her pillow. She contemplates throwing him out of the car, as she would often ride in the back, just to make sure he was okay. But it was at those times that she would contemplate throwing him out of the moving vehicle. And the only thing stopping her is fear of getting in trouble with the law. And so now she reaches a point where it doesn't even matter anymore. She's at home alone with her son, and she now has a plan. She decides that she's going to throw him out the window. So we're going to put a pin in that really quick and just define what postpartum depression is. So one of the definitions is that it's depression suffered by a mother following childbirth, typically arising from a combination of hormonal changes, psychological adjustment to motherhood, and fatigue. And it's also classified as a mood disorder. While the exact cause of postpartum depression is unclear, it is believed to be a combination of physical, emotional, genetic, and social factors. And current research is also in support that postpartum depression can be experienced by both the mother and the father. And so looking at the epidemiology of this within the United States, the prevalence of postpartum depression is lower than that of the global approximation of 11.5%. However, it is varied between the states, ranging from as low as 8% to as high as 20.1%, with the highest prevalence in the United States being found among American Indian, Alaskan Natives, and Asian Pacific Islanders. It's also approximated that 60% of United States women in the United States go undiagnosed, and then 50% of those that are diagnosed are going untreated. It's also estimated that the maternal postpartum depression rate around the lower socioeconomic status women of this country is about 40 to 60% higher than those not in this social class. And so while there is discussion of postpartum depression in fathers, there's currently no formal diagnosis of this condition in them. And it is still estimated, without there even being screening, that as many as 10% of fathers who just had a newborn baby experienced postpartum depression themselves. So signs and symptoms. This can occur anytime within the first year after the baby is born. And typically the diagnosis of postpartum depression isn't even considered until signs and symptoms persist for at least 2 weeks. And so some of the emotional signs and symptoms would be persistent sadness, anxiousness, mood swings, frustration, irritability, restlessness, anger, feelings of hopelessness or helplessness, guilt and shame, low self-esteem, numbness and emptiness, and just a feeling of overall, like I'm just existing, exhaustion, inability to be comforted, trouble bonding with the baby, feeling inadequate in taking care of the baby, and then also thoughts of suicide or self-harm. And then some behavioral signs and symptoms. So lack of interest in or pleasure in doing usual activities, low libido, changes in appetite, fatigue, decreased energy and motivation, poor self-care, social withdrawal, insomnia or excessive sleep, and worry about harming self, baby, or partner. There are also neurobiological signs. So there were fMRI studies performed on mothers with postpartum depression, and what they did find is that there were less activity in the left frontal lobe and increased activity in the right frontal lobe. And the mothers with postpartum showed a decreased connectivity between vital brain structures. And this made it clear that there are neural activity changes in those with postpartum depression, and it's happening in the regions of the brain that are very important for self-regulation, empathy, and emotion. And so some of the causes, while the actual cause of postpartum depression is unclear in mothers, it is theorized that things such as physical changes, a personal history of depression, family history of depression, the stress of caring for a new baby, and then even hormonal changes is believed to be the culprit behind this. As far as hormonal changes go, there are hormones like estrogen and progesterone that actually builds up, of course, as we know, during pregnancy. But what happens is after pregnancy, within 24 hours, it drops back to pre-pregnancy status. So it is believed that that sudden change is what attribute or can contribute to the cause of postpartum depression. And then there's also the use of synthetic oxytocin, which is that birth inducing drug. This has been linked to increased rates of postpartum depression and anxiety. And then there's estradiol. So this is a hormone that helps to thicken the uterus so that the baby can grow the way that he or she needs to. And it's thought that it contributes to the development of postpartum depression due to its relationship with serotonin. So estradiol levels rise during pregnancy and then drastically decreases following childbirth. And when those estradiol levels drop after the baby is born, the serotonin levels also decline. And so serotonin is a neurotransmitter that helps to regulate the mood. So low serotonin levels can cause a feeling of depression and anxiety. And then fathers. So although fathers may not have undergone the profound hormonal changes as mom has undergone, it's still recognized that they are at risk, that they are at risk for experiencing postpartum depression as well. And this is due likely to the profound lifestyle changes in having to care for the infant, caring for the mother, and then also just this new relationship communication dynamic that the father is experiencing with the mother of his child. And one of the strongest predictor of paternal postpartum depression is having a partner who also has postpartum depression. And this makes fathers of a child with a mother with postpartum depression 50% more likely to have postpartum depression. So that is pretty significant. And then also just less personal time. So just even going to the gym, we know can help our mood. So things such as that can contribute to it. And then there are risk factors. So there aren't many predictors of women who are more vulnerable, and therefore we can't say that they're at an increased risk. So it's still believed that postpartum can happen to anyone, and that everyone is basically on the same playing field. As long as they've given birth, they have the potential to end up getting postpartum depression. But with that being said, there still are some risk factors. Again, the oxytocin administration that I spoke about earlier, chronic illnesses, previous history of postpartum depression, hormone irregularities, inflammatory illnesses, cigarette smoking, and then some psychosocial risk factors. So pregnancy and or birth complications, and mom to multiples, a teen mom, substance abuse, victims of domestic violence, stressful life events and or transition, low social support, low socioeconomic status, a lack of emotional support, poor marital relationship or single marital status, breastfeeding difficulties, formula feeding rather than breastfeeding, and infant temperament problems. So those that have like colic and are crying for like 2 to 3 hours on end, prenatal depression or anxiety, history of childhood trauma or abuse, personal and or family history of depression, an unplanned or unwanted pregnancy, and cultural factors, especially in places like the Middle East, Asia, and Africa, where having a female baby instead of a male baby may be frowned upon due to the, certain values that are placed on male babies when compared to female babies. So in those mothers, they are 2 to 4 times more likely at risk for having postpartum depression. And so for diagnosing postpartum depression, the criteria for the diagnosis of postpartum depression are the same as those required to make a diagnosis of non-childbirth related major or minor depression. And so the criteria is that at least 5 of the following 9 symptoms must occur within a 2-week period. And so the first 4, feelings of sadness, emptiness, or hopelessness nearly every day for most of the day, or the observation of a depressed mood made by others. So someone else can also say that this is different for the mother to be acting this way. Loss of interest or pleasure in activities, weight loss or decreased appetite, changes in sleep pattern, feelings of restlessness, loss of energy, feelings of worthlessness or guilt, loss of concentration or increased indecisiveness, recurrent thoughts of death with or without plans of suicide. And so there are some differentials. So a lot of these aren't officially diagnoses, but they fall under postpartum depression. And one of these are postpartum blues, also known as the baby blues. This is more transient in nature. It can come and go. It usually is resolved within 2 weeks. There are milder depressive symptoms, and it's believed to affect around 80% of mothers who give birth. And then there is postpartum psychosis. This is not a diagnosis. It's not formally diagnosed, but they will use it in cases of psychiatric emergencies. It appears in about 1 in 1,000 pregnancies and is characterized by more severe symptoms. This is basically what the YouTube video, the mother in that video depicted. It was more of a psychosis that happened, and they can cite thoughts that are racing. They can be more confused, loss of inhibition, have paranoia, hallucinations, or even delusions. And then there's childbirth-related postpartum post-traumatic stress disorder. And so currently there are no widely used assessments to measure PTSD in the medical settings, but there are some that are used in research settings. But what is actually needed for a diagnosis of this is for there to be a real or perceived trauma during, before, or even after childbirth. And so sometimes the mother would describe being easily startled, have recurring nightmares, flashbacks on giving birth, and then may even avoid her baby or anything that reminds her of giving birth. And they may be more aggressive, irritable, and have panic attacks. And so it's estimated that up to 50% of the cases of postpartum depression actually go undiagnosed, and therefore screening for this condition is critical. And so the American College of Obstetricians and Gynecologists, ACOG, they suggest that providers actually administer the depression screening at the prenatal visit while the mom is still, pregnant. And then the American Academy of Pediatrics suggests that parents are screened, or I should say mothers at this point, because fathers aren't necessarily recognized right now, but mothers are screened for postpartum depression at 1, 2, and the 4-month visits. And the most widely used scale for screening for this would be the Edinburgh Postnatal Depression Scale. And so prevention. There was a Cochrane review that found evidence of interventions after childbirth that actually helped to decrease the risk of postnatal depression. And so these interventions included home visits, telephone-based peer support, interpersonal psychotherapy, and then the emotional closeness and global support of the partner. Support is a very important aspect of prevention, as depressed mothers commonly state that they had feelings that brought about the postpartum depression that would include having a lack of support or even feeling isolated. And then in couples, the emotional closeness and the global support by the partner actually protects against the perinatal depression. So even before the baby is born, it protects against depression and then also anxiety. And so there was a study that was conducted by Asaloon and Cora that found when they compared 42.9% of women who did not get support from their partner, only 14.7% of the women who did get support from their partner actually had PPD. So that's a huge difference. And then there is counseling. So for those who actually have positive risk factors, they can actually establish mental health counseling prior to delivering so that they can reduce the risk of them getting postpartum depression. And so for treatment, one form of treatment is therapy. There is individual counseling, there's peer support, there's cognitive behavioral therapy, interpersonal therapy, and well, cognitive behavioral therapy, just, I don't want to just throw that out there, but that's when therapy focuses on changing and challenging the distorted thinking patterns associated with behaviors, and this is thought to help improve the emotional regulation. And then the interpersonal therapy is basically therapy that centers on resolving interpersonal problems and thereby hopefully resolving and recovering from the symptom. And then there's support groups and group therapy, and those two forms of therapy a lot of times help assist in finding further treatment options. And then there's medications. So research does suggest that mothers with postpartum depression will respond similarly to those that are diagnosed with major depressive disorder. And with that theory, they believe that using the serotonin, the selective serotonin reuptake inhibitors, also known as the SSRIs, that they should also be effective in treating women with postpartum depression. And so the first line of antidepressant therapy of choice is called Zoloft, and it is the drug of choice because very little of it passes into the breast milk, and as a result, the theory is that very little passes on to the infant. But there has been controversy regarding the use of these antidepressants with a phenomenon called antidepressant-induced suicidality. So a lot of times individuals, and since we're talking about mothers, they're started on these drugs because they are depressed and because the depression itself isn't resolved, and we put them on the SSRIs. While they're at their ultimate low, they end up reaching an ultimate high. And if they decide to stop taking it, or they miss it for a significant amount of time, then they come back down to that ultimate low. And if they already kind of were contemplating suicide or had a plan, it's usually at that time that would happen. So close follow-up is definitely recommended, but there's no clear-cut guidelines on what close actually is. And then there is hormone therapy. And so that is supported by the idea, of course, of how we spoke about earlier, the estrogen and the progesterone, just the hormones, and how these levels drop drastically post-delivery. And that is thought to help contribute to the depressive symptoms. So giving replacement therapy is thought to help regulate things and thereby decrease or probably even treat postpartum depression altogether. And in 2019, Vexanolone is a steroid. Well, it's a synthetic analog of a steroid that helps to eradicate the postpartum depression symptoms. It is given IV, and it is thought, and actually trials show that within 48 hours of them being started on the IV and given this medication, their postpartum depression, the effects of it is pretty much gone. And in 2023, so this year, zuranolone was approved, and that is the pill form of Vexanolone. And so what are the implications of postpartum depression? For mothers, there is definitely a general overall diminished sense of their quality of life. And so we may see a woman that seems all together and everything's going well for her, but her perceived state is that of unhappiness. And then there's also the sleeping difficulties, the appetite changes. The postpartum depression can also hinder bonding with the infant. She can miss the social cues in needing to take care of her infant child, and even miss things such as singing, affectionate touch, reading to the baby, just kissing, things that would help to enhance the baby's formation of secure attachment It's vital for their emotional well-being, and this can be missed due to postpartum depression. Then even just the child's needs being changed, being repositioned, being fed, um, and the activities of daily living can be missed. So mom can even fail to take care of herself and can become ungroomed and unkempt. And then also just the effect that it can have on her own mental state. 'Cause a lot of times with these mothers, they feel like a failure. They feel like they are not good parents. They feel like they're not good enough and they're failing to meet their infant's needs. And so their mental health can change even subtly from just mood changes and trouble in concentrating, and then also go to the other end of the spectrum where they are having thoughts of committing suicide. And let's not leave out fathers, as I said before, they also are at risk for postpartum depression. And so they are at an increased risk. So mothers having postpartum depression, like I said before, has an increased risk of the fathers having postpartum depression by 50%. They can be hard on themselves. They can also have doubts regarding their own parenting skills. They can be more irritable, angry, and or even aggressive. And then they can just offer inadequate support. So with them having it, let's say the mother does not have postpartum depression, with them offering inadequate support, we just spoke about how the global support can help prevent a mother from going into depression. So if a father gets postpartum depression, they can actually cause mom to be at risk for now acquiring postpartum depression. And then just the role of the father, they can really contribute to helping the mom, or, adding to the mom either getting it, or if she already has postpartum depression, it can just send her even farther into that. So now we're not just talking about childbirth, but now we add on to that marital discord. And so implications for the infant, I'm sorry. So there would be the impaired reaction with the mother that we just spoke about, sleeping difficulties, developmental delays can begin to surface. They can become colicky. They can also be on the opposite end of the spectrum where they're very quiet and or passive. And then they can also have physical deformities. So this is an example of one physical deformity. This is called plagiocephaly. And as you can see, the posterior portion of this baby's head is very flat. And on the right side, you'll see what a normal view would be. And this was after it was corrected. So it is able to be corrected, but sometimes it can take even up to a year. And this is also the effects of the previous picture. So when there's that flattening of the posterior portion of the head, it causes, the head shape to shift. And so as you can see from this frontal view, it just kind of widens the view of this baby's face. And so we know that with normal babies, especially when they are infants and they're just born, their muscles are very immature. So even sometimes turning their head will be something that has to be done. So torticollis is another physical deformity that can arise. And this happens when a baby tends to look one way or the other more often than not. They tend to favor one side. So in this case, the baby's favoring the right side. So I see this a lot in practice, even without parents that have postpartum depression. If a mom is right hand dominant and they hold the baby in the left arm, the head is right here. And a lot of times they turn in towards mom's body. And so that ends up being the side that they favor the most. What happens is over time, if the baby turns his head to a certain way more often than the other side, this side of the neck that it is turning to is short as in terms of the muscles, but then on this side, it's longer. And so it ends up contracting that way. And even when you try to pull the baby's head and turn it, it's very hard to do because the muscles are set that way. And so this can be resolved with physical therapy. It's not necessarily permanent, but it is a byproduct of a baby not really turning their head. And so this becomes a problem with postpartum depression, because if they are missing the social cues, or they do have that detachment and they're not picking baby up and, allowing for that position change regularly, this is something that can happen. And then there is the torticollis plagiocephaly. So it's a combination of both of them. So the baby is favoring one side while not being picked up regularly and is spending prolonged times on their back. And so this is just a bird's eye view of the way the head shape looks for that. And so we saw the implications on the mother, the father, and the infant, and now for the siblings. So for toddlers and preschoolers, sometimes they can become less dependent. You might see a regression where they start acting like the baby. They're less sociable, may even start playing by themselves, and become also detached. Issues with discipline, become aggressive and destructive, and could even have poorer school performance once they are in school. And then for school-age children, they can exhibit behavior problems, have trouble learning, be at increased risk for acquiring ADHD, which is attention deficit hyperactivity disorder, which is hallmarked by hyperactivity, impulsivity, and inattention. So not being focused, not paying attention. And then they also can have poor school performance. For the teens, they would exhibit exactly the same issues as the school age children, but then they also can fall into major depression. They can develop an anxiety disorder, conduct disorder. They can fall into substance abuse, and then also have learning difficulties. So in conclusion, with the high prevalence, despite the underreporting of postpartum depression as evidenced by the rates of those that are undiagnosed, and then the variability of the screening guidelines, and coupled with the transgenerational effects. So we saw what can happen with those children. So when you talk about ADHD or substance abuse, even the father falling into depression, the mom. So all of this has the ability to now go across the lifespan. And so we're not talking about a snapshot of time, but this could end up becoming a new disorder or a new problem for each of those individuals in the family. So with all of that being said, this definitely constitutes a public health issue. And so that is it for the first half. Are there any questions or concerns?
Thank you so much, Dr. Edwards. We have a small group, so I'm gonna go through and allow folks to speak. We may not need to use the chat, so I'm just going through, and I should have clicked on your name and it will say allow you to speak. So if you have some questions and reflections on what you've heard from either the case studies and or anything that you've heard today regarding postpartum depression. Each time I hear a session, I learn so much more, and it causes me to think of other questions start bubbling up. But before I think about what I would like to ask, you can unmute now. Is there anyone who has a question thus far? Go ahead, Jamie.
Hi, thanks for
Hi,
that.
Jamie.
Hello, thank you for this great presentation. This is dynamite, and something I was just talking about with my team the other day. Just curious as to what we over here in New Hampshire have not seen anybody with getting those newer meds, with the IV stuff and whatnot. What has that been like for rolling out in your experience?
I primarily deal with those of, with public insurance, lower socioeconomic status. So it's definitely not something that is offered on their plans. And I do know that it's very expensive. Even in doing the research, a lot of case studies was were saying that they were receiving it, and then once they stopped receiving it, the postpartum depression ended up coming back. And so just from that, I knew that it was expensive and that not many people have access to it.
Perfect. Thank you.
Anyone else? I guess for me, and as I mentioned, a lot of times when I'm sitting in the presentations here, I'm also that student. And so this time I heard, thinking about correlation between family, right? Past history around mental health or trauma and how that can impact. And I just also thought about, I have a background in education. And so oftentimes we're doing a lot of family advocacy. Of course, these are school age children, but families, I'm really advocating families for full health assessments, right? We see them experience crisis and things at school or families in trouble. And we often try to connect with healthcare providers. So I'm just wondering, how can we, as in the mentoring session, right? We are in different roles in community, maybe public health nurses, maybe in programming. And we're seeing moms in community or supporting them. Is there some general information or practical steps as say like even a community health worker? Like what could we recommend that they do? Is it going to their, because oftentimes, right, after you have the baby, you switch back to maybe your family doctor opposed to your GYN. So where do you direct people back who might need some additional support?
That is so on time, because that is the second half of the mentorship. And so, yeah, I don't want to spoil it,
Okay.
but I'm trying to think for now, because the first half was really like where we are and like what the current guidelines are. So for now, they do say to refer them back to the OBGYN. They also suggest giving them resources for mental health therapy so that they themselves can get involved in that. But that is truly why I wanted to do this today, because I'm passionate about doing more and changing that, because a lot of times what I'm seeing is they are so depressed that they're not even caring for themselves, much less to actually go out and pack up the kids or find a babysitter for them to now go to their mental health therapy session. And then in terms of the OBGYN, the whole system is kind of overworked. So you don't really have time to counsel. If you're in your lane as the provider, as like a pediatrician or the OBGYN, you're not necessarily having the time in the day to offer mental health therapy, nor are you trained adequately enough to address these issues as well. So that is part of my problem, because I am getting a lot of positive postpartum depression screens even while I'm in practice. And I do spend quite a bit of time calling the OBGYN on those positive depression screens and trying to actually connect with them. But because they're so busy, they don't get back in touch with me. And then my case, like the follow-up there is definitely cracks. And when we talk about all of the implications it can have, we can't afford for that to happen.
Thank you. Is there another question? We're doing great on time. Another question before we move on? Let me look at this. See, is there? Okay. There was one. I'm sorry, Mary. I'm just seeing your question in the chat. It says, speaking of access, we live in a rural area with limited access to PPD care. So what suggestions do you have to help these women?
So yeah, that will be in the second half. And then I do have a handout. The only thing the handout doesn't have is resources for fathers yet, because this was made prior to that. But at least to answer your question, Mary, it will have that as a handout for them to reach out to these nationwide resources. And then I do have a couple of more practical steps, like low-hanging fruit, that we can implement in our practice every day so that we can help them while things change, hopefully.
Wonderful. Thank you. Thank you. All righty. Let me see, there's another one in there. Mary said thank you. All
Oh, thank
righty.
you.
Okay, I think we can move on.
Okay, so now the mentorship portion. Oh, sorry. Okay, so the Edinburgh, this is the most widely used scale. It's meant to take no more than 5 minutes to complete. And it specifies that the symptoms should occur within the past 7 days. And so these are all 10 questions. We'll go through it together. I'm just not sure, if everyone on here has seen it, so I don't want to assume. So we can go through it rather quickly, but these are the 10 questions. So I have been able to laugh and see the funny side of things as much as I always could, not quite so much. Definitely not so much right now, and not at all. And then I have looked forward with enjoyment to things as much as I ever did, rather less than I ever did, definitely less than I used to, and hardly at all. 3, I blame myself unnecessarily when things went wrong. Yes, most of the time. Yes, some of the time. Not very often. No, never. I've been anxious or worried for no good reason. No, not at all. Hardly ever. Yes, sometimes. Yes, very often. I have felt scared or panicky for no good reason. Yes, quite a lot. Yes, sometimes. No, not as much. No, not as all. No, sorry, no, not at all. And then 6, things have been getting to me. Yes, most of the time I haven't been able to cope at all. Yes, sometimes I have been coping as well as usual. No, most of the time I coped well. No, I've been coping as well as ever. 7, I've been so unhappy that I've had difficulty sleeping. Yes, most of the time. Yes, some of the time. Sorry. Let me go back. Yes, some of the time. No, not very often. No, not at all. I felt sad or miserable. Yes, most of the time. Yes, quite often. Not very often. No, not at all. 9, I've been so unhappy that I've been crying. Yes, most of the time. Yes, quite often. Only occasionally. No, never. And then last but not least, 10, the thought of harming myself has occurred to me. Yes, quite often, sometimes, hardly ever, or never. And so scoring this, it's 0 to 3, with 3 being the most serious of all the options. And then it uses the reverse scoring method. This is intended to reduce the potential of response bias. And so what happens is all of the mother's scores from all 10 questions are added up, and scores that are greater than 12 or 13 would indicate that this mother's most likely suffering from postpartum depression. And so as we just discussed, more often than not, our suggestion is for the mother to go to OBGYN or to give her a list of mental health therapists and hope she follows through on that. And so I did want to just touch on another case study, and I do remember we didn't finish the first one, but let's just look at this one really quick. So there's this writer that's based in San Diego, and she recalled her experience of her son's birth. And she described it as being in labor for 28 hours. She struggled to breathe and had a mask strapped to her face. Her epidural failed. Her water was broken without her consent. She ended up having an unexpected episiotomy, which we just got done saying her epidural failed. And then there was a presence of NICU doctors, and some people are aware that, NICU implies that there could be something wrong with the infant. She mentioned that, so she probably knew of the NICU doctors, so that made her uneasy. And then her body was shaking in shock. And so she actually made the statement that, she said, you feel so powerful growing a baby, and then to go from that to feeling so powerless was such a strange juxtaposition of feelings. And so she said she felt incredibly vulnerable emotionally, physically, and spiritually. And so she actually ended up taking the same Edinburgh survey at her 6-week checkup, and she answered those questions that said she felt like she was scared or panicky for no good reason, or that she's been able to laugh and see the funny side of things. But she said that her experience was not reflected in the surveys at all, and that she also hoped that the nurse would be able to see something or say something that she could not vocalize. And so in her case, she was ultimately, based on the survey, diagnosed with postpartum depression, but she said that there was no follow-up on her mental condition. And it wasn't until a year later that she found out that she actually had post-traumatic stress disorder, which, if left untreated, can arise in other health issues, ranging from, issues with the heart to even substance abuse. And even for that, she didn't receive any formal treatment, but in the end, she ended up feeling better. She ended up journaling, she did a lot of talking and connecting with others, and ultimately that's what helped her to get out of the postpartum depression. And so, gaps and challenges, this is kind of where we were going and why I chose this topic, because I do see a lot of gaps and challenges in the current way that we handle postpartum depression. And so the first thing would be the screening guidelines. There's definitely a disconnect between the recommendations and the symptomatic occurrences. So ACOG, of course, says during the prenatal visit at least once. And it probably should be more than once, because there is a spectrum of, her carrying the baby. There's the first trimester, the second trimester. These are all different. There's different ranges of emotions that happens throughout this time frame. So to do it once, it's kind of like, well, which time do you pick? So the screening guidelines in terms of prenatal is one thing, and then postnatal, the American Academy of Pediatrics suggests that we do it at the 1 month, the 2 month, and the 4 month. That's not capturing the newborn visit, and she could be experiencing, signs and symptoms, and needs to be, kind of coached along or educated about this, even within the first 4 weeks. 2 weeks is the baby blues, they say, but it's not far-fetched for it to even, start there. But then there's that 2 to 4 week gap that things could also happen, that's not accounted for. And then in a lot of these cases that we're seeing advertised in the news, the babies were like 6 months, 7 months old. And so clearly postpartum wasn't gone at that time. And for the American Academy of Pediatrics to say, 1, 2, and 4 and stop there in terms of their recommendation. I know it's not stringent, and there are a lot of offices that probably even do it up to 6 months. But according to even the DSM-5 and just the diagnosis of postpartum depression, it's recognized that it can occur within the first year. And then there are studies that also show that it could even occur even at the 15-month visit. So I do feel that the guidelines needs to be addressed. And then with the screening guidelines, that also can interfere with the rates of those that have been going undiagnosed. And so then the screening tools being used, this Edinburgh that we just went over, there's a lot of gaps in that as well. So again, I touched upon this before, it speaks nothing about risk factors. So there needs to be like questions regarding risks prior to the baby even being born. And then even when the baby is born, like if the mother, we saw that one of the risk factors was being born, having multiples. So if the mother gives birth to triplets, now we already know she's at increased risk. None of that is accounted for even in the questions being asked. All of the questions is geared towards the mother. There's no questions regarding how the mother even feels about the children, like are the baby temperaments that such of like colic, or they're inconsolable? Does mom feel any frustration in caring for the baby? These are all important questions to be asked. The last question on the Edinburgh was, are you having thoughts of harming yourself? And so the mother can say no, but she could also have thoughts of harming the child, which was not actually even asked. And that's not something we can expect for people to just outwardly come out more often than not. They're not probably going to disclose that. They'll think that they are crazy and that they shouldn't be thinking these thoughts. They may be even feeling shameful and guilty because they really do genuinely love their child and they shouldn't be having these thoughts at all. And then none of these screening tools, I believe, are capturing the differential. So we talked about it may capture the postpartum blues, but postpartum psychosis and thoughts of suicide. Other than that question, there's hallucinations, there's the racing thoughts, there's even the PTSD, those differential diagnoses where mothers more often than not have these stories that they tell about their experience giving birth, and a lot of them are traumatic. The one that I just kind of read to you for the case study 2 is not uncommon. I'm hearing mothers that have been in labor for 3 days and had a lot of other things, like they had this birth plan that they were working with, and all of a sudden they're now having major abdominal surgery with a C-section that was unplanned, and all of things that happened in between that time. So none of that is being captured in the screening tool. And then children aren't being screened. And this one may be farther down the pipeline, but I do feel it's something that needs to happen, especially when we're talking about the rates of children that are being diagnosed with developmental delays. The diagnosis of ADHD is on the rise, and to know that these are potential contributing factors, like a mother having postpartum depression, and that now, implicating the children, that's not addressed. And so even if we do not take the opportunity to address that when we are doing postpartum visits, at the very least, it needs to be translated in the community when we are trying to put these children on ADHD medications, or if we're trying to find out the root cause of these developmental delays. It may be as simple as attributing it to postpartum depression and helping mom out of that. And so fathers, again, not screened. And we just got done speaking about how fathers can highly contribute to the problem, or they can actually help mom and support her out of that problem. And so either end of the spectrum, fathers are very integral, like when it comes to a mother giving birth. And then there are no clear-cut guidelines on following up on these positive screens. So I know oftentimes, even for me, I just being very transparent due to certain workloads, like I will follow up with that OBGYN the one time. If they don't call me back, I have not necessarily consistently followed up until I actually got that provider on the line. It was almost like I did my due diligence the first time, and just due to workload, not because I don't care, but just because it slipped through the cracks, there's just no clear-cut way to follow up on every single positive screen. And then access to mental health care providers. I myself, because I care so much about this topic, I have reached out, because a lot of times, a lot of the providers will, especially in the offices that I've come from, they will give mom the referral they will give mom a list of providers. That's now where we come to, because so many are like with full panels of patients and they're not accepting patients. So I myself will personally call on behalf of the patient and try to set that up so that I can at least know that we have something going, and then I can follow up with the mother instead of trying to play, tag with the other provider. So I will oftentimes try to set that up myself, and I, as a provider, am reaching a barrier where I'm calling, and again, the panel is full and they're not accepting patients, or the ones that are accepting patients, the first available appointment is 3 months down the line. And especially if we're talking about mothers that answer yes to some of these questions, as long as it's not, hurting themselves, because for that, we would do more of like an emergent thing. And even I've been known to even, call the ambulance and just speak to mom about it and let her know why. So in those situations, I'm not talking about. But in the other cases where there is these positive postpartum depression scales that we know that they have postpartum depression, I, as a provider, am getting these barriers. So I can only imagine a mother that now has a newborn baby that is depressed, that has even more than my eye can see, because I'm only seeing baby and mom. I'm not seeing the marital relationship or the lack of a relationship. So she's doing it alone, and all of the other things, her financial status. So that is a challenge. And so this is where we get into the clinical considerations that could possibly help in the interim while all of these other gaps and challenges are addressed, hopefully just through us doing more talks like this and bringing more awareness. So increase the screening, of course, during the prenatal visit, doing it throughout the visits, just like we would do in the primary care setting. So the newborn visit and every visit up through the 12-month, if there is a positive depression screen following up, even within 2 weeks based on the score. So just even changing the criteria on follow-up and screening, I should say. And then also screening fathers, how do they feel? Their perception on mom's behaviors and affect, they can give a lot of insight. So I do have some moms that just want to get out of the appointment, so they kind of answer all the good questions, even though it is reverse scoring. You can see that I can see that they're not necessarily like reading the questions, and some even refuses to fill it out because it's just another piece of paperwork that they have to complete. So getting the dad's perception is could be very vital. And then giving dad resources. And then screening for children. This one also may be a little farther out. Like I said before, I think the immediate focus would be on just getting mothers and fathers screened, I think would be better, because then they could actually help with the children. But assessing their feelings about the new baby, their perception of mom and her changes. And it could even be done through like a FACEY scale, where they don't necessarily have to vocalize and read a question and circle the answer, but maybe even just a face of how they feel towards their mom and their dad, their mom and their new sibling. And then revising the screening tool, so reflecting more of the symptoms. We went through probably like 5 pages worth of symptoms. I know we can't necessarily put all of that on a depression screen, but having questions that attribute to the postpartum psychosis, the postpartum post-traumatic stress disorder, and then even speaking about the babies, questions about babies, all of that will help to just gather more information and kind of give more voice to what they can't vocalize, kind of like what was said in that case study. And I believe too, it would normalize that this does happen. If the question isn't even being asked, sometimes the mother just doesn't even know. So where she may not have said, or where she, may not have said that she was thinking of harming the baby, the fact that the question was on there with 4 different choices could give some out, even if it's not her vocalizing exactly what she's thinking or feeling. And the new screening tools, I think, should be developed. So one that assess for the risk factors that could be done in the prenatal setting. One that can even allow them, like, put all of the symptoms and just have them kind of circle it. I know that we do have like a ACE concussion form. It's for the acute concussion evaluation. And it just has a whole bunch of symptoms like photophobia, photosensitivity. It has whether you're vomiting, nauseous, whether you're irritable. It just goes through all the symptoms that someone can experience if they have a concussion. And I believe it's more than 20. But all you do is just circle like one. I'm sorry, it's not yes and no. It's 0 and 1. So you go through and you circle 0, 1. 0 meaning you're not having those symptoms. 1 meaning that you are. And then what happens is we're able to score that, and at the next visit administer the same thing, and you at least have some measurement of whether or not the problem is getting better or worse. So sometimes they will complete the next one. We usually bring them in every week if they're positive for concussion. And if the first time they filled it out, it was a 7, but then the next time they come in, it's a 5, we know it's getting better. But if it's the other way around, we know it's getting worse. So developing just a simple symptom tracker that can be circled is something that's easy. And then again, having a screening tool, assessing feelings and thoughts towards the babies, or even the baby's temperament, like my baby's crying all the time, the baby's inconsolable, things like that could help. And then just plain open-ended questions so that you can give the mother space to write something that she couldn't necessarily see in the question, but that she can actually write out and vocalize herself. And so this was the question that Nicole, you asked. And so what would I do? And this is actually what I do even now. It isn't necessarily something that, of course, that's put in place, but I actually try to have kind of like a birth plan. So when I gave birth to my son, we were given this handout, and it said, when your baby is born, how would you like the room? Would you like the lights on? Do you like it dim? Do you want music on? What's your favorite kind of music? Would you like candles? It says, what would you like your birth partner to do? Do you want him to, like kind of stay and just support you, or do you want him to massage your back? Would you like a birthing ball? Do you want a water birth? Like, there was just a plan put in place prior to me even giving birth. And I believe that postpartum is happening so much that, and it's so prevalent that it can have something as simple as a birth plan, so that in the event the mother does not go to the mental health provider, or does not connect with the OBGYN, or they can't afford the meds, or they don't want to take the meds because some are just anti-medication, just having a nice birth plan. So you have your OBGYN as a quick reference. You have the section with your partner. What would you like them to do? How can they help you? And then it could even say, that they don't have a partner. That's where we can involve family and friends. And so you can say, what would you love for your friends and family to do during this time after you give birth? And it could even ask, do you have a history of postpartum depression, or your first time mom? Because even if they are first time mom and has never had postpartum depression, this means that they are at an increased risk for being anxious, because they don't necessarily know what to do, even with a newborn baby. And then a lot of times mothers forget themselves in the process of having a baby. They forget their hobbies, they forget what they like to do. They're not putting on makeup anymore. They've gained all this weight. They really just have lost themselves. And because of the time constraints and all of the competing priorities that they have, they just do not have time to do anything else. And they forget that even 5 minutes of drawing may help to ease their mind, like if they are artistic, maybe singing. So even just having them write this down so that if they're in that mindset, they can remember who they are. Meals is another thing. So like even saying, what is your favorite meal or what's your favorite restaurant? And so that these things can be, ironed out and like in plain sight so that even while they're forgetting, 'cause a lot of times you get, what can I do for you? And at that moment, you can't really think what you can do for me. Like this will already be on paper. And at the very least, these things can be done. And then even visiting, like how would you like visiting to go? Um, you know, would you want them to be, would you want visiting hours? Would you like just getting all of this information ahead of time can help to support mom and allow for her to have this plan in place and give it to those who she actually are close to and who will be, in close support of her. And then even if she doesn't necessarily have anyone because she's kind of more like alone, it allows her to start thinking in her head, who can I talk to? Who can, be around me during this time? Because after she gives birth, that's just not the time to do it. So that was my answer to your question, Nicole. And so further recommendations, it would definitely be social support for sure. I think that would be um, the biggest treatment. And as we can see, even in the case study too, the mother said that she didn't have formal treatment. No one followed up on her. She didn't have um, any medications or anything like that, but yet she came through on the other side, and it was through journaling, it was through talking, it was through connecting with others. And so until all of those things I mentioned, new screening tools, revised screening tools, screening dad, like until that stuff happens, there is things we could do as a community to try to address the gaps in these areas. And some of the low hanging fruit is just educating mothers and fathers on the symptoms, the importance of their support, mom's role in possibly causing dad to go into depression, dad possibly causing mom to go into depression, the discouragement of and then also, again, the effects on their children. That's huge too. And then discouraging isolation. So a lot of times, some people already have an introvert personality, and now you couple that with postpartum depression, just letting them know that this can make a huge difference in whether they spiral down into depression or they, prevent that from happening. And then educating them on the role each other can contribute in helping in the condition. As for healthcare providers, there's way more across all of the disciplines that will help to contribute to this, but I just listed 3. But just taking time, 1 to 2 minutes out of their lack of time, because I know that, they're overworked, but just taking 1 to 2 minutes just to speak about postpartum depression, and rather than waiting for the next visit. So just thinking in your head, what if this person never goes to a mental health therapist? What if this person never takes their medication? What is it that I would want to say? So looking at them as if they're not going to go anywhere else, so that you can make it your priority to tell them the important things and even allow them to share. And also, even if they have a negative postpartum depression screen, still just having like a very quick spiel, so that if in the event they end up falling into depression outside of the visits, because it does get spaced out, just letting them know that it is still real and all that. So for me as a clinical provider, I actually just kind of give a spiel to mothers and fathers, and the way that it kind of looks is I'll say, so mom, this depression screen is showing that you may have a little bit of postpartum. Do you feel that way? And a lot of times I'll get yes, or like I didn't know that it was, or no, I don't feel it at all. Like I feel like I'm good. So the question or the answers ranges from that question to no, they don't feel it, to yes, I do, and some of them will immediately start crying. So it's a whole spectrum. But even for the ones that says no, they are not experiencing it, and I'll say, okay, well, this may be picked up on something that you may not be aware of, and just because of that, I'm going to say to you, make sure that you know, accept help, and that if nothing else, I want you to like, and I'll ask them, you know, like who makes them laugh, or do they have their mother, do they have their sister, like who are close to them, is it their best friend? And if they mention whoever it is, I'll say, okay, just make sure this week you make time to get with them. That is like your homework for the week, or that is the medication I'm giving you, like that's what you need to carry out. You have to get with someone this week. And sometimes, like depending on, they'll say, you know, I don't have childcare, I don't have this, and I'll say, well, who is available? So it helps them to start thinking, not I don't have, or this is the current state, but how can we, you know, get these pieces of the puzzle in place? And so a lot of times they'll be like, well, there is so and so, or there is, so it just gets them thinking. And then if the fathers are in there, I will say, so dad, I just got done saying that to mama, so I want you to just love her, like love, 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 love. And then they'll a lot of times smile, or they'll start hugging the mom. And then I'll say, and mom, just because you gave birth to the baby does not mean that daddies can't be going through it, because there sometimes we can give off, you know, just emotions and an air that we're not aware of, and dad is getting all of that. And so at the same time, daddy, I'm telling you to love mommy, and but mommy, I'm telling you to love daddy too. And so then you'll see them hug a lot of the times, or they'll be crying, but they're at least realizing that a lot of times they are arguing for no reason. So that will be my next thing I'll say. And I'll say, so from the time that, you know, from this time all the way until I see you next time, there is no argument. So a lot of times they'll start laughing, and I'll be like, there's no arguing whatsoever. There's nothing too big. There's nothing too small. There's just evidence that whatever you're arguing about probably is beyond you. Like it's probably hormonal. It's not really the problem. It's like you guys are arguing with each other when it really should be the problem that we should be attacking. So that a lot of times helps to at least involve the fathers, make the mom aware, and just kind of get their minds going. And it really does kind of put them in a different space. Oops, why? Okay, and so this was a handout that I was talking about. So I believe it was Mary. This was something I can make sure that I can give to Ms. Fernandez so that she can pass it along to you. And a lot of these are national. So some of the ones I was going through was specific to Georgia. And I just kind of made it national so that it could translate to everyone. And then this is the back part of it. And so the second part of the case study, the first one. So remember, we were at the point where she now had a plan. She was going to throw her baby out the window, and she didn't care about whether or not she would get arrested or get in trouble. But at the point where she was about to do it, the window was up. Someone walked in and suggested that the mother move the baby away from the window, not because the person knew why she was at the window, but because they felt like the baby could catch pneumonia, and you know, shouldn't just be by an open window in the north when there's snow falling. And so the mother broke down crying, believing that the person actually knew why she was at the window, not knowing until later that it was due to them thinking the baby could acquire pneumonia. But she actually thought at that time they knew exactly what she was about to do. So this person knew that faith was important to her and brought her to her pastor. And the pastor prayed over her and then suggested that she goes to see the OBGYN. The OBGYN diagnosed her with postpartum depression, of course, and prescribed Prozac for her. And the mother then went home and told her mother, so it's the infant's grandmother, but she went home and told her own mother what transpired and that she was put on the medication. The mother knew that she didn't really want the medication, so she just volunteered to help. She actually kind of moved in with the mom just for a short period of time, not necessarily all her stuff, but took enough clothes and toiletries so that she can spend like a week or two there. The mom cooked, cleaned, helped care for the baby, made her laugh, and just provided companionship. And then with that, she ended up being able to get even more rest. The symptoms then subsided, and when the mother was pregnant with her second child, she immediately told the OBGYN because she knew what it was now, and she didn't want the same thing happening with the second baby. So the OBGYN then decided to send out the visiting nurse services. And these nurses would come out, and it was agreed upon by the OBGYN and the mother that these nurses would come out once a week unannounced, and the door needed to be answered, or they would put out a CPS case, just given the history. And so the mother was aware and in agreement with the plan. And that mother was me. So I definitely did not fit in that mold that I would have, like, even when I took the postpartum depression scale, I could or could not have been diagnosed with postpartum depression. It never asked me any questions of whether or not I wanted to harm my baby. I definitely thought I was the one that was going crazy, when really there is evidence that this is a common phenomenon that does happen with mothers. And so in conclusion, there's just so much to be done. There's so many bridges that need to be constructed to get from where we are to where it actually needs to be in relation to screening fathers, like even having something as simple as a birth plan be a standard, making sure that we consider this when we're dealing with children and diagnosing with ADHD and developmental delays and all of that. So again, we would need to involve many stakeholders, such as the OBGYN, the pediatric providers, mental health therapy, mental health professionals, I should say, the legislators, insurance companies. And so with that being said, despite all the progress that has been made, there's just still so much to be done. And that's why I said so close yet so far. And so we as a community, we do have the ability to just grab at the low hanging fruit and do something in the interim, which would at this point just be to recognize and educate as much as possible and not leave it up to the status quo, not just leave this up to the current guidelines, but even just do a little bit more in educating our families about this condition. And any other questions?
Wonderful, wonderful. I just want to thank you. And we are doing great on time, everyone. So we do still have about maybe 20 minutes for some more robust conversation and or discussion and or feedback and reflection.
No, you're muted.
I'm sorry, I'm talking. I just wanted to thank you for that wonderful presentation. And I just want to let everyone know you still are able to unmute. Please share a reflection or comment or anything that you would like to share with Dr. Edwards. Well, I will share what I heard and that I'm going to take away. One, thank you for being so transparent and sharing your own experience as a case study. We often know culturally in many communities that, you know, you have to have that superwoman persona of having everything together and knowing how to respond. Or even if you've been a mom before, you know that, oh, well, she knows what to do, or she's fine. And overwhelmingly what I heard, or one of the number one barriers, not only from your discussion, but from previous presentations and educations I received, time is the barriers, one of the biggest barriers for practitioners. They don't have enough time to triage and or support families. So I know that's something legislatively and policy wise, and when we're thinking about patients' Bill of Rights, that we really need to address, making sure providers have enough time in order to respond, to be responsive to the care needs of their clients. And then also what I heard you say more clearly than before, in terms of, again, being exposed, like you said, we have a lot of this information, but what can we learn and how can you help us to move closer to being supportive and helping to support moms so that they're not in crisis, right? We want to prevent those crises from happening, or more further harm caused to mom and baby. And you talk about communication, you talk about the need for community. This is a comprehensive, collaborative approach to care. And it is beyond just the health practitioner, that it also resides in the family, it resides in community. And that birthing plan, I did not think of the birthing plan that really is a postpartum plan also. And so with that birthing plan, you're also trying to help us understand indicators, ways of building relationship and trust with our patients, to understand who do they have relationship with, where are their supports. So should something arise, like you said, you have that information, and also helping mom and partner or husband, right, understand these are her wishes. This birthing person wants to make these choices. These are the things that they're raising up that are important. And so I heard the community taking action, resources, and then further education and support. And so I just really appreciate you driving those messages home about the diversity of need and care as we move forward together.
Thank you. Thank you for that opportunity to share it.
Thank you. Anyone? Okay, let me just see. I see something here. Jade said, thank you so much for sharing your experience. I can't think of any questions as I am not practicing and don't have much experience in this area, but have learned so much from you and your story.
Awesome.
That was Jade.
That was a hope.
That was Jade. And then let me see. So Mary had put in the chat also previous while you were presenting. She says, here at our hospitals, we read all Edinburgh questions while they have it in front of them. We screen all patients so we make sure they clearly understand the questions prior to discharge. So that sounds good to me, Mary. I'm hearing you say, right, it's more intentional to make sure, one, excuse me, there's time and understanding what they have in front of them.
Very, very good.
And then, so Mary also responded when you shared the case study. I believe this was case study number 2 when this was up. She says she will most likely have a childbirth related postpartum stress disorder. She needs support after she leaves the hospital. She needs to have follow-up with her OBGYN within 2 to 3 days after discharge. So Mary's problem solving, right, as you were sharing that.
It was happening. I love it.
Definitely, definitely. I love the tool that you have shared with us, and I know everyone will be anxious to get that and share it. I think that our time has been really well spent.
I
Tennisha,
think Jamie's raising her hand.
oh, I'm sorry, Jamie. Go right ahead.
No problem. Thanks for sharing that, you know, the personal aspect of it. I think that we all have been at a point in our lives where we can relate to some of those things that you were feeling. I just wanted to share that here we have a pretty robust program that I'm quite proud of in our state and with our local hospital. There's a postpartum support coordinator that works, 5 days a week that sees these moms for up to about a year after they deliver. If just for touching base and helping with anxiety and depression and racing thoughts and all of those things. And she has the tools where she can refer to a higher care level as needed, which is super helpful for our families. She does try to go in and meet the moms before they discharge from the hospital, but she gives everybody a call probably about 2 to 3 weeks after they've gone home to touch base and see how things are going. And that, program started probably, I don't know, 20 years ago as a little short, tiny grant that has evolved into a full-time position that the hospital has, which has been great for our moms in the community. I'm a visiting nurse, and we have a large maternal child health program here at our agency where we go out and we do new visits for all moms that deliver in our area at the local hospital about 2 to 3 days after they get home, where we go out and we do a well mom assessment and a well baby assessment to make sure that everybody's doing okay and settling in and surviving the roller coaster that they're in. And so we frequently see moms where there's starting to be some depression, some baby blues, all of those types of things. And so we've gotten very good at doing some Edinburghs and reaching out to the OBGYN, reaching out to the postpartum support coordinator at the local hospital to try to help these moms and really give them what they need so that they can be successful. So just wanted to share that.
That's beautiful. No, we need that here because I have a lot, and we do not have that. I would really love to know, was it a national grant that helped that?
No, it wasn't. And so actually the one for the hospital with the postpartum support coordinator, I can't remember exactly where that grant came from. But the visit that we do, we call it a baby's homecoming visit. And the expectation of the hospital for us is that we go out within 2 to 3 days of them coming home and do those assessments, like I had said. And it actually started probably, I don't know, about 25 years ago from one of the OBGYNs who, God love him, he used to call his patients, a week or two after they were home to see how they were doing and settling into life with their babies. And he developed this endowment, a Healthy Families Endowment that people in the community contribute money to, and we ask for money from them to help to fund it, but then overall our local hospital funds the expense of our visit to go out and see all of these moms and babes that deliver with them.
Yeah, that's beautiful.
Yeah, it's really great. And I think, you know, the local hospital probably does around like 1,300 births a year. And I think that we are going out and seeing like probably, I think last year it was like 875 moms we did. So out of that, you know, 1,300, that's fairly decent, I think. And yeah, and I think it's a well-known thing in the community, and the providers expect it, basically, because they know so much, you know, how valuable it is.
Wow. Yes, thank you for sharing that. I'm going to try to see if I can develop something like that here in Atlanta, even if it's not, because I don't work for a hospital, but clearly those resources are out there. Hopefully I can find one that's specific to Georgia.
I think Mary had a question. She had her hand up.
Hi, this is Mary, and I'm from a hospital in Southern Illinois. We currently work with Illinois Perinatal Quality Collaborative, and you know, they do a bunch of initiatives related to maternal and fetal health and well-being, also in equitable care as well. And one of the reasons why I went to took part in this program is because in 2024 we are looking at maternal health as our new initiative to work on. And you know, we realize that more women are dying in their postpartum stage. 26% pregnancy death, 42% occur in the 0 to 1 year mark, and only 27% are medically that are quote medically having a medical condition related to those. So I was really interested in your program to kind of take notes and figure out what we can kind of start on. And we're looking at, you know, the AIM, the Alliance for Initial on Maternal Health, things to do. So of recognition and prevention and readiness and reporting and systems. And of course, we're always looking at the respectful, equitable, and service supportive care with every mom. So thank you so much for doing this. I just wanted to let you know.
Well, thank you so much for joining me. I really, really appreciate your attendance here, because you all will go out and make the difference that the community actually needs.
Thank you, Mary and Jamie, for your questions, and I hope that you'll follow up with us. Tennisha, I don't know if you want to share your email or contact information, but I would love to know about that particular grant, even if it's in your area or region. If you wouldn't mind emailing and or sharing that information so that we can kind of maybe key into maybe who in our local areas might have additional funds. And then I think it was Jamie, are the people that also help to provide support, are they community health workers that are working with the nurses?
No, we're all nurses. It's a team of all nurses that does it. So, and we're all pretty much have always worked in like labor and delivery, NICU, that type of thing. So we're definitely dedicated to, you know, to our care that we give. But yeah, we're all nurses that do it.
Okay, wonderful, wonderful. I just know so many. I just recently did a certificate program here at St. Kate's with community health workers, and I was just really fascinated at all the different areas. Now, like, I didn't even know about community health workers as, quote, right, this evolving profession and or career. And now you're seeing more and more folks even related to, you know, education or community organizations. They're using community health workers in a lot of that support area. And I know in Minnesota, we're developing, like the African American Babies Coalition. They have a whole training that is like a cultural responsive training. And so they're using parents as teachers. They're talking about home visiting. They're being trained by one of our cultural wellness centers on like just cultural norms. Our populations here are Latino, East African, Hmong, and African American, and other Asian or indigenous cultures. And so just having reaching out to community to get that information and then provide that training so that people feel more comfortable and equipped. And so that's one thing that I know we're doing here, and they're really looking forward to working with nurses and community health workers, because they believe those are the ones who are doing that work on the ground, you know, building those relationships with families and seeing moms and when they're leaving the hospital. So thank you. I see Jamie and Mary shared their contact information as well. Okay, everyone, we're at 150. There was one other comment in the chat saying a phenomenal presentation. Thank you so much for the transparency of sharing your story, and is both courageous and inspiring. And I think there's just one more before we get ready. Okay, and then Tennisha has shared her contact information in the chat. Again, I want to thank everyone for attending this mentoring session. I will send out certificates. I am behind in my certificates, but I will get them out by Monday of next week. Also, I want to again thank SAMHSA and the Minnesota Department of Human Services on this mentoring session. Each of you will receive a short survey. If you would not mind, please completing that, sharing your information and recommendations for any future sessions. I do know we will be having a mentoring session in this last cycle of this grant. We are crossing our fingers and hoping that we get this grant extended for more time. And if you have any speakers or you have a flagship program that you are doing and that is making the difference, please consider coming on and sharing in our regular maternal infant health series that happens on Wednesdays from 12 to 1 o'clock Central Hour. And then lastly, my final announcement is we are having an online conference on January 17th and 18th. It is focusing on SUD and OUD perinatal care. We are looking at asset management, perinatal care through the 4th trimester. I'm really happy to have Dr. Titus Glover from Maryland. She will be speaking. We have a doctor from Cal Baptist and Mass General. So I worked really hard to try to get doctors across the nation and specialists who are working in this field, as well as some local presenters. And so you'll also find that on our website. I posted the link to that before we started, or in the same area that you find our series recording and postings of upcoming sessions. So thank you, everyone. And we look forward to seeing you at another upcoming session. Thank you again, Dr. Edwards, for really sharing such an intentional presentation on mentoring and education so that we can serve more families better. Thank you, everyone.
Thank you so much. Thank you, everyone.
Have a great afternoon.
You too.